Hi and welcome back to another video of Medic Notes. This video will be on cervical cancer. Cervical cancer is defined as a malignancy originating from the squamous epithelial cell or glandular cell of the cervix, where it starts at the transformation zone, which is at the squamo-columnar junction at the cervix. There are two main types of cervical cancers, which are squamous cell carcinoma and adenocarcinoma. These are the risk factors of cervical cancer. Those who have persistent HPV infection, especially the types 16, 18, 31, and 33. Those who have abnormal cervical cytology, such as cervical intraepithelial neoplasia. Immunocompromised patients. Early sexual intercourse. Multiple sexual partners. Young age at the first pregnancy, or any previous history of having a partner with sexually transmitted diseases, multiparous woman, cigarette smoking, low socioeconomic status, and also the use of combined oral contraceptive pills. These are the risk factors of cervical cancer. The use of COCP is due to association of non-barrier method and also exposure to HPV. For clinical features, in early stage of cervical cancer, the patient may not have any symptoms, and sometimes the cervical cancer is diagnosed after routine cervical smear. Other symptoms they might have are postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding, foul-smelling or blood-stained vaginal discharge, and also constitutional symptoms like loss of weight and loss of appetite. Whereas for advanced diseases such as stage 3 and 4 of cervical cancer, they may have pain, such as lower abdominal pain due to large pelvic mass, or back pain due to vertebral metastasis. Other symptoms they might have are urinary or bowel incontinence due to fistula formation, anemia due to chronic vaginal bleeding, and also signs of renal failure due to ureter blockage. So for physical examination, we can do general examination and examine the cardiovascular system and also respiratory system to exclude for metastasis. Abdominal examination can be done, however, there is usually no mass palpable, but in advanced stage, we may able to palpate the mass. Speculum examination is done to inspect the cervix and vagina to look for any abnormalities such as growth, ulcers, and polyp. These are the characteristics of a cervical tumor. Cervical tumor is often fungating, or they might have ulceration, cauliflower shape, bleeding on contact, friable, there might be stony hard on palpation, look for signs of inflammation and discharge, and it is less mobile when it grows to the surrounding tissue. Bimanual examination can be done to assess the uterine size, the mobility, any tenderness, and also induration and thickening of the parametrium and vagina. Per-rectal examination to assess for parametrial involvement and also to rule out involvement of the rectum. The investigations that we can do are blood tests such as full blood count. This is done to assess the hemoglobin level to rule out anemia due to chronic vaginal bleeding. Renal profile to exclude ureter obstruction, and also liver function test to exclude liver metastasis. The investigations for staging are rectal vaginal examination to identify the size, fixity, and also vaginal involvement. Ultrasound to assess the uterus involvement, chest x-ray to look for lung metastasis, CT scan or MRI scan of the abdomen and pelvis to detect the local spread of the cancer and also detect any enlarged lymph nodes. Cystoscopy and sigmoidoscopy to exclude bladder and rectal involvement. Intravenous pyelogram to look for urinary tract obstruction by the lesion or to look for hydronephrosis. And intravenous urogram can be done to check the integrity of the uterus. This is the clinical staging for cervical cancer, which is the FIGO staging. So there are 4 stages. Stage 0 is the pre-malignant lesion, which is the cervical intraepithelial neoplasia. In stage 1, the tumor is confined to the cervix, where it can be divided into 1A and 1B. So 1A would be microscopic disease, whereas 1B is macroscopic disease, more than 5 mm depth, and the width is more than 7 mm. So stage 2, the tumor extends beyond the cervix, and it involves the vagina and or infiltrate the parametrium. So 2A and 2B. 2A is it involves the upper 2/3 of the vagina, and 2B it infiltrates the parametrium. Whereas stage 3 can be divided into 3A and 3B. 3A is the tumor extend to the lower 1/3 of the vagina. 3B it extends to the pelvic wall and or hydronephrosis or non-functioning kidney due to the urethric obstruction. Stage 4, 4A is it involves the bladder or rectum or extend beyond the true pelvis. 4B is there is distant spread to other organs. So for the treatment, it is different for different stages. For preclinical lesion, like stage 1A, it is treated safely by complete local excision, especially in cases of pre-invasive disease. And if the treatment fails, we can repeat a loop biopsy or knife cont biopsy. After stage 1A, the treatment for stage 1A, the advantage is it can preserve the fertility of the patient. Whereas if it progressed to stage 1B, it is considered clinical invasive cervical carcinoma. So from stage 1B to stage 4, we can do surgery, which is the Wertham's hysterectomy in premenopausal women. And it involves the radical hysterectomy plus pelvic lymph node dissection. So this Wertham's hysterectomy is removal of the cervix, the upper third of vagina, uterus and parametrial tissue, and also the lymph nodes involved, whereas the ovaries can be spared. Another surgery that can be done is the radical trachelectomy, which is a fertility-sparing surgery, and it removes 80% of the cervix and parametrial tissues, plus resection of pelvic lymph nodes. The second mode of treatment is radiotherapy, which is done for stage 2 to 4. It is to deliver a little dose of radiation to the tumor and also minimize damage to the surrounding tissues. And there are two ways of radiotherapy, which are the external beam and internal radiotherapy. Some of the side effects of radiotherapy are fatigue and diarrhea, skin erythema like sunburned skin, and also bowel perforation. And the third mode of treatment will be chemotherapy, which is usually used cisplatin. So this is the summary of the treatment for different stages. Stage 0, we use cryosurgery, cont biopsy, or loop diatomy. Stage 1A, we can do a complete local excision, loop biopsy, or cont biopsy. Stage 1B, for premenopausal women, do a radical hysterectomy, Wertham's hysterectomy, or radical trachelectomy. And postmenopausal women, the ideal treatment would be radiotherapy. Stage 2 onwards, can do radiotherapy with or without chemotherapy. So that's all for this video. Thank you.